So we move on to the second topic of this CINP member panel. And this second topic concerns the practical clinical strategies on how to treat and manage patients with bipolar disorder. Would you like to make the major contribution?
Thank you very much. And indeed, it's a very difficult topic, as we've spoken about. Bipolar depression, when it becomes treatment resistant, is often very resistant to multiple strategies. And in Australia, many clinicians would start with for instance, a combination of mood stabilisers or a combination of mood stabiliser and antipsychotic, and we tend to use very much quetiapine, olanzapine and lorazepam in that context. We would often use a combination of mood stabiliser and lamotrigine, of course being cautious about the interaction potential between valproate and lamotrigine. And we may also consider olanzapine and fluoxetine. Of course, there was the significant meta-analysis by Taylor in 2014 suggesting that is a strategy that ought to be utilised. Generally in Australia, when those sort of strategies have failed, then we're looking at combinations of either mood stabilisers and antipsychotics, along with medications like bupropion or SSRIs, and then we may move to other medications such as modafinil and pramipexole. ECT, of course, remains a mainstay of treatment for treatment-resistant bipolar depression. Often in clinical practice, though, when we've exhausted our ordinary Australian guidelines, we're looking even further afield than those mainstream strategies, and we may, for instance, move towards strategies such as other neurostimulation techniques, such as TMS. We may be looking at light therapy, although that has a less efficacious base in Australia because of our very strong light in Australia. And we've also been influenced quite heavily by Gordon Parker, Professor Gordon Parker and the Black Dog Institute, and looking at other things like stimulants, although they have a lesser evidence base. So there are many similarities between our guidelines and CINP, and a few small differences. For instance, in Australia, pramipexole is less often used, perhaps, than it would appear in the CINP guidelines. And so those are the sorts of strategies that we might implement. One of the most important things, though, practically, when we're looking at prescribing, is of course personalised medicine, is trying to tailor the treatment to the person in front of us, both in terms of what's likely to be efficacious and acceptable, but also in terms of really working with people to understand their patient preferences. The obvious example being the limitations of olanzapine, although a very robust antipsychotic and mood stabiliser, it has some significant limitations in terms of metabolic syndromes and weight gain. And there are some patients who will not, who, despite it being an effective treatment, will not countenance the idea of olanzapine treatment. And so we very much are wanting both efficacious treatment and acceptable treatment in algorithms. Even still, there are people who, despite our best efforts and carving out treatments that are very tailored, struggle to overcome symptoms of resistant bipolar depression, and so it remains a very significant clinical conundrum.
So. I would like to add to that I think oftentimes when you're dealing with a sort of patient with treatment-resistant bipolar depression, you're dealing with a patient population that oftentimes they present with significant severe depression symptoms, and one of them, as I mentioned before, is suicidal ideation. What I want to go is, like, we have really limited medication in psychiatry in general that work in suicidal ideation, with an exception of lithium or clozapine, which are actually tailored medication for bipolar behavior, for suicidal behavior and not suicidal ideation. I think in this context, novel drugs like ketamine, which recently was approved, the version of one of the enantiomer known as ketamine was approved by FDA. seem to have pretty robust effect not only in the alleviating the depressive symptoms, but also relieving relieving the suicidal ideations. And one of the studies that we have conducted at NIMH that is probably one of the two randomized clinical trials that was conducted in bipolar depression looked at the effect of ketamine in bipolar depression patients. And what we found is that within the same time frame, that ketamine is relieving depressive symptoms, which is like significantly shorter period of time. Like you're talking here within hours to days, and this is after a single infusion, 0.5 milligram per kg. Ketamine decreases the MADRS item score 10 for suicidal ideation, and this is robustly. And what is interesting is like such therapeutic response is maintained up to a week. So when we are discussing about practical guideline, I oftentimes think about that emergency doctor, which I've been one of them, in the middle of a community hospital when admitting a patient with severe depression symptoms and severe suicidal ideation. So how do you want to tackle that? And I think drugs like ketamine, probably in U.S. market, they just made it to the market, but I think there's a significant need for novel drugs, rapid-acting drugs in the field of bipolar disorder in general, but bipolar depression in particular. And I think we've been lucky enough to have witnessed the latest change, like 3 approvals, like 2 approvals within the span of weeks, span of months in the U.S. Of esketamine and brexanolone. Both of them, right now are the guidelines are for use of treatment-resistant depression for adults. But I think we have evidence that esketamine may work in bipolar depression as well. And you have the brexanolone, which is approved for postpartum depression. But one of the studies looking at the adjuvant treatment of one of the close brexanolone family is known as SAGE 217, seemed to be working in depressed subject. And I think there's significant hope, hopefully, in the future for the patient, but I think we also have to be cautious of the challenges that lie ahead.
Practically speaking, there are many challenges
Yeah.
to in the everyday management of this patient. One of these challenges is that often when they are in mild hypomania, they have low insight, they don't really understand, they don't really realize they are they're sick. So they go on and have all types of behaviors, of risk-taking behaviors, and they ruin their personal and economic lives. And their relatives also, they are not quite sure whether this is a morbid condition or some variation of normality. And then when they have a depressive episode and they relapse into an acute manic episode or hypomanic episode in the early phases, patients and relatives together, they consider it an improvement.
Yeah.
And also there are all these sentimental problems that you need to persuade them that some of these risk-taking behaviors are not completely normal, are not for the best of the interest of the patient. And this comes with a very fine-tuned pharmacological intervention, because you need to tackle as much as the patient needs, but not more, because more, sometimes in bipolar disorder, more is less. You give more antidepressant, you switch the patient.
Absolutely.
You give more antipsychotic, you switch the patient into depression, or you produce any kind of mixed episodes and complex things. So you need to fine-tune the practical management.
Well, I think you're discussing a very relevant topic, the switch phenomenology. I think we don't know. There's little or no studies that looked at the switch phenomenology per se. In fact, the neurobiology of what undergoes in somebody's brain and somebody have that propensity to switch. I think you're discussing some of the sort of like treatment guidelines. They even include SSRIs or SNRIs or medication like stimulants. I mean, when people are highly treatment resistant, and these are classic medications that actually can induce switch phenomenology. Another group of medication which I often see in the National Clinical Center at National Institutes of Health, because we're dealing with, when I see patients outside the scope of psychiatry unit, you're seeing patients with in high steroid therapy or like immune deprived therapy, and these patients, because of their deprived immune system, steroids actually oftentimes induce either manic or psychotic symptoms, and then you have another facet of problems how to deal with that. So I think we need a better scientific understanding of of the switch phenomenology, the biology per se, but also we need to be cautious about, you're saying right, to kind of fine tune when we are like, what are we using, because it takes a little bit of pharmacological like insight to be able to really stabilize these group of patients.
Indeed, switching is a really, really difficult clinical conundrum. My clinical experience is that there are some patients who tend to switch and some that don't, and in many ways the phenomena of switching may well have more to do with patients themselves than the pharmacological agents. That being said, it's very clear that there are some pharmacological agents that are much more likely to cause treatment emergent effective switching. Venlafaxine and tricyclics are of course much more likely. As you said, indeed stimulants are as well. Curiously, lamotrigine can also cause switching, and lorazepam can on occasions. So that there certainly are elements in terms of our treatment that we need to be very careful with and fine tune, and we also need to pick our patient carefully, because people with a history of switching or rapid cycling are much more prone to these disorders. One of the other curiosities, of course, about some of the literature is many of the descriptions of effective switching are done in relatively short trials, and we know that in those short trials you may only see 10 or 20% of switches, where if you leave it for 12 weeks you may see many more switches than that. And indeed the difference between SSRIs and venlafaxine will be demonstrated in looking at longer follow-up studies.